Hello, I am Parakkal Deepak, a third-year gastroenterology fellow at Mayo Clinic in Rochester, Minnesota. On behalf of all my co-authors, including my mentor David Bruning, I would like to thank the ASGE and the editors of the Gastrointestinal Endoscopy Journal for allowing me to publish and present my research. The title of our manuscript is Incremental Diagnostic Yield of Chromoendoscopy and Outcomes in Inflammatory Bowel Disease Patients with a History of Colorectal Dysplasia on White-Light Endoscopy. Patients with ulcerative colitis and colonic Crohn's disease are at an increased risk of developing dysplasia, which is believed to be related to chronic inflammation and is thought to follow a stepwise progression from long-standing inflammation to dysplasia and in some patients to carcinoma. The recent scenic guidelines suggested chromoendoscopy rather than white light endoscopy for initial dysplasia surveillance in inflammatory bowel disease patients. However, the yield of chromoendoscopy in patients with a history of dysplasia on white light endoscopy and the impact of chromoendoscopy on management plans for patients with a history of colorectal dysplasia remain unclear. Additionally, characteristics of dysplastic lesions identified on subsequent chromoendoscopy procedures are unknown. We identified inflammatory bowel disease patients with colorectal dysplasia detected with an index white light endoscopy who subsequently underwent chromoendoscopy at our institution between January 1, 2006 and August 31, 2013. Patients who had undergone a colectomy and were undergoing surveillance of an ileal pouch anal anastomosis were excluded from the study. Chromoendoscopy was performed at our institution by spraying the colon with 0.2% FD and C blue number 2 solution, which is similar to indigo carmine. A combination of targeted and 32 surveillance biopsy specimens were performed at each chromoendoscopy. Endoscopic and histologic findings were compared between the index white light endoscopy and first and subsequent chromoendoscopy. Endoscopic appearance of visualized lesions, which was defined as any abnormality leading to targeted biopsies, was further classified based on the Paris classification. Histological grading of lesions was characterized based on the Riddle classification. Several outcomes were measured, including surgical rates after the first chromoendoscopy, the indication for surgery, types of surgery, surgical pathology findings, and the identification of additional areas of dysplasia on follow-up. The detection of flat versus elevated visualized dysplastic lesions as well as the dysplasia miss rate were compared between the index white light endoscopy and the first chromoendoscopy. We identified 95 cases in our study with a median age of 58 years and a median inflammatory disease duration of 18 years. Our study patients were predominantly male, with most cases identified among patients with a history of ulcerative colitis and pancolonic disease extent. 23 patients were noted to have a history of primary sclerosing cholangitis, while a family history of colorectal cancer was noted in 21. The first chromoendoscopy was performed after a median of 6.1 months. This identified dysplasia in 59 of the 95 patients. Of these, 50 had dysplasia that was visualized. The first chromoendoscopy identified 40 new lesions in 30 patients, of which 6 were only noted on random biopsies. Visualized lesions were more commonly located in the cecum and ascending colon. The first chromoendoscopy compared with the index white-light endoscopy was 19 times more likely to detect flat dysplasia. The first chromoendoscopy compared with the white-light endoscopy was also 93% less likely to miss dysplasia. Endoscopic resection at the time of chromoendoscopy was performed successfully in 43 lesions, most commonly located in the cecum ascending colon. The findings on the chromoendoscopy triggered a surgery in 14 patients, which revealed colorectal cancer in 2 and high-grade dysplasia in 3. A subsequent chromoendoscopy was performed in 44 of 95 patients, which detected dysplasia in 20 patients, of which 30 were new lesions. The majority were again located in the right colon and were of low-grade dysplasia, except for one case of high-grade dysplasia. They were, for the majority, resected during endoscopy, though 5 patients were referred for surgery due to multifocal dysplasia detected on chromoendoscopy. The implications of our study are: number 1, chromoendoscopy is better than white-light endoscopy at detecting flat dysplasia in inflammatory bowel disease patients. It is also less likely to miss dysplasia. Number 2, most of the visualized dysplastic lesions during chromoendoscopy can be resected at the time of endoscopy. And thirdly, continued surveillance with chromoendoscopy is recommended after the first chromoendoscopy, since we detected new dysplastic lesions after the first chromoendoscopy and detected multifocal low-grade dysplasia that resulted in surgery. The next step would be to continue to follow this cohort to better understand if the new lesions continue to be detected at the subsequent chromoendoscopies and if there is a survival benefit. Also interesting as a separate study would be to look at the patients who did not have dysplasia at the time of the second chromoendoscopy to see if they do develop dysplasia down the line. This might help us identify patients who may benefit from infrequent screening with chromoendoscopy. Thank you very much, and I appreciate your time.